Hello, everyone, and thank you for joining the webinar today. This is our first Fotona Roundtable webinar, which is a different format than we've had previously with Academy programs, where it is a formal presentation along with patients being treated. The purpose of today is to meet our trainers. And we've got a wonderful group of trainers across Canada that I would like to introduce to you all. So I'll ask the trainers to all take their, to hop on camera and take off mute. Right from the West Coast, we have Nikki Havers, who is not in attendance today, unfortunately. She is in a training. She is with in British Columbia and covers, she's our gynecology specialist. You can see next, as we move from the West Coast in, is Teresa Maloney. Teresa is in Alberta, and she covers Alberta, Saskatchewan, and Manitoba. It's with great pleasure that I say that Teresa has been with Clarion now for 15 years and is a wealth of knowledge. So we've just helped her to celebrate her 15th year. Moving across the coast, we've got Siobhan Lynch. Siobhan Lynch is in Ontario. She is our clinical trainer here, as well as, if we jump up top there, is Sarah Jane Fitzpatrick. And Sarah Jane Fitzpatrick is our national skincare trainer. She looks after quite a portfolio of things. We call her the goddess of all things skin. So she's hopped on to join us today as well. And then further to our East Coast is Marie-France Legault. She is our clinical trainer that resides in the Montreal area. She looks after Quebec and the Maritimes. We do have a new nurse that has joined us as well. She's going to be a student today instead of a panelist, but be sure and expect to see her in our next roundtable session. It's Marie-Josée Parisien, which I'm very, very pleased to have had join us December. So I really appreciate everybody taking the time today to spend just a couple of hours with this session. But first and foremost, I do want to remind everyone that we have people that have joined across Canada who all have a different, may have had a different experience with Fotona. We've got varying levels of backgrounds and expertise, as well as importantly, comfort levels. So there may be a protocol, there may be a treatment or an indication here that we're going to discuss today that may be beyond something that you may be new to Fotona. And this is where you're to write that note down and speak with your clinical trainer at the end of the session. So I will include everyone's email addresses as well as where they're located so that you can reach out and ask those one-on-one questions. We do a wonderful job of doing all kinds of virtual training and hands-on training to get you to that skill level where you're able to do some of the perhaps advanced indications. So I didn't introduce myself. I'm Tricia Meisner. I am the clinical director here at Clarion Medical Technologies, and welcome to our first session of Meet the Trainers. So I'm going to, we're going to switch over now. I've got just, what I'm going to do, folks, is I've got 13 topics that have come in that we've seen a bit of a trend on questions, general questions around topics. We've narrowed them down to 13. I'll introduce the topic, and then we've got a clinical trainer that will speak to that topic. You may have 2 to 3 questions, or sorry, we can use the chat. So if you look at the right-hand side of your screen, there is a chat box. I'm happy to filter questions. We may be able to answer 2 to 3 questions on each topic, and then we'll need to move on. So please, if your question hasn't been answered in this session, your clinical trainer will be happy to answer following this, and we will follow up with an email to everyone that's attended. So please stay tuned, and I'm just going to switch over to a PowerPoint. Hang on a second here. So if Sarah Jane and Teresa, if you want to turn your cameras off. Wonderful. Okay. So we can see we're going to start with our informal PowerPoint. So again, we'll just introduce the topic and then we'll be able to move through it in this format. Just want to make sure that our chat button is enabled. So Jennifer just said the screen is not showing. Are you able to see the screen now, Jennifer?
Yeah, we can see it now, Trish.
Wonderful. Thank you, thank you. Okay. So we're going to start off. We had an inquiry into the Fotona hair restart program. It is we do have a bit of a combination protocol, and I'm going to ask Teresa Maloney in Calgary to start off with discussing it with the Fotona system, and we'll have Sarah Jane then follow up with potential combination therapy using our World PRP system.
Can everybody hear me? Can you hear me, Trish?
I hear you, Teresa.
Okay. Good morning or good afternoon, wherever you're coming on for this call. Yeah, I'm going to talk a little bit about the hair restart that the Fotona can do. And when we do hair restart, we work in smooth mode. We have different parameters for it. You can use the PSO3, and you can also choose to use the R11 to do this procedure. And what we're trying to do here is we're trying to do a heat shock to the hair follicle. And by doing that, we stimulate, the growth factors, resulting in improved hair growth. By customizing this, it stimulates the dormant hair follicle, and you don't need to use anesthesia, and you don't need to have surgery. When you're looking at having something like this done, it's always looking at that 10-year period of where people have started to have their hair loss, if that's where you're going. I mean, alopecia is a totally different thing, but if it's just standard hair loss, at about the age of 18, we start to lose our hair. We don't notice it as much because we're still getting new hair growth that is coming in. And then as we tend to get older into our 30s, we start seeing that thinning of the hair and the baldness. And what this can do is this, again, can help stimulate the dormant hair follicles for regrowth. When you're doing treatments, I mean, it's usually done about every 2 to 3 weeks. 2 weeks is fine. You want to look at 6 to 8 treatments, even up to 12 in some cases. And you can combine this with PRP, which Sarah Jane will be talking about in a moment. But when you look at the factors of hair, of why we lose our hair, I mean, you're looking at hereditary, hormonal changes, some medications people have taken, radiation that they've had, stress. I mean, there's many reasons of why people have lost their hair, but this is a wonderful way without causing a lot of downtime for people. And, especially if men are doing it, not to cause discomfort and pain with it and have this done. It's really showing promise in the before and after pictures we have, and even more promise when it's combined with PRP. So Sarah Jane, if you want to talk a little bit about how PRP brings this on to even help it more stimulate than just the laser, I'll turn it over to you.
Excellent. Thank you, Teresa. So to piggyback on Teresa with the hair restart program there and incorporating that into your smooth mode using Fotona for hair restart. As Teresa mentioned, the hair restart can be done every 2 to 3 weeks. When you're piggybacking or having that combination or global approach by incorporating PRP into the patient's treatment plan, for example, their first treatment would be done, hair restart would be done first, and then the PRP injections would be done the same day right on top. Following that, 2 weeks later, the patient would come in for hair restart as a treatment again, and 2 weeks later following that. So every second hair restart treatment that the patient's coming in, you can obviously use you would use the PRP on top if you've included that as part of your combination approach for treating your patient. So just as a review, PRP is platelet-rich plasma. Obviously, we're utilizing the growth factors that are found within our PRP. There's over 30 different growth factors that have been identified. And two modalities are happening when you do incorporate PRP into the patient's treatment plan. First, it's the injection site that stimulates natural fibroblast activity, and then obviously doing the microbolus and planting the PRP into the patient's scalp. And then, you know, lucky for us, we don't have to monitor too much. The platelets know exactly what they're doing. They go to those dormant hair follicles, and then we'll stimulate and awaken them. I do strongly believe when you are introducing PRP or recommending that as a treatment option, or having again that combination therapy, that the expectations are laid out clearly for your patient, and your patient selection is also going to be important. If, you know, the hair loss has been longer than a 5-year or 6-year span, you know, the expectation and outcome may not be as significant as someone who's been losing hair for the last 3 to 5 years. Also laying out clear expectations that the end result, there isn't a statistic, you know, using PRP, you're going to have a 50% increase in hair loss. It's always going to be based on the patient's overall health and obviously the blood platelet levels that each patient contains, and we don't have that information per patient. And on average, each patient will have, you know, roughly 150,000 platelets per microliter up to 400,000 platelets. So we're not able to determine who falls in what category as far as that goes. So I do think clear expectations of PRP injections, but there are a significant amount of studies out there that show the benefits to using PRP for hair restoration and hair loss in patients as well. We see best results across the country working with a lot of our partners. I've seen they typically are recommended in series of or sold in packages of 3 treatments. Some of the feedback that we've received as well is sometimes it's that 4th and 5th treatment where you can really see significant changes in the skin. And when you're speaking to patients, I always like to recommend or explain it like with PRP, we're aerating essentially the scalp, which, as I mentioned earlier, stimulates fibroblast activity. And then we're placing these growth factors using the platelet-rich plasma. It's kind of like fertilizing that area in the scalp. One of the things when looking at PRP, you really want to consider concentration is obviously a factor, but certainly platelet dose plays a huge part in that. Obviously, the more growth factors and platelets we can inject, or the more platelets we can inject into a patient's scalp, the more growth factors will be released. And with the World PRP system, we're looking at a roughly, on an average, if the patient had roughly 200,000 platelets per microliter, you're looking at being able to do that therapeutic level of PRP. So really injecting 1 million platelets per microliter. On an average, we're able to extract close to 4 billion up to 6 billion platelets per patient. So definitely are seeing significant improvement using the World PRP system, excuse me, for the patients as well.
Thank you, Sarah Jane and Teresa, for providing that insight. I do not see any chat messages at this time. Again, you're more than welcome to email afterwards. We'll move into, we had a question around spider veins and treating spider veins, and I believe Marie-France is going to walk us through that now.
Yes, can you hear me?
Yes, ma'am.
Can you hear me?
Yes.
Okay, my apologies. So yes, I would like to talk to you about spider veins. So we have great results. We're using, of course, the Nd:YAG, so FM 64 nanometers. We can treat a skin type from 1 to 6. And what I've noticed, the treatment is very efficient, and it takes few treatments to see results. So I think that the recipe for that, first of all, never ever overlap pulses. Also, you really need to use your Zimmer cooling before, during, and after the procedure. And also we recommend to apply a thin layer of gel because it protects the epidermis, and also it's a good hydric contact with the skin. So this is what we suggest. If you are not very advanced and you start with the technology, it's much better to use a 6 millimeter spot size. Bigger spot size, deeper the energy. So for the face, we recommend a 6 millimeter spot size with 90 joules. Usually we have small veins, so we use in between 10 to 15 milliseconds. However, it can happen that you have bigger veins or more darker veins, and you need more pulse duration. You need to have a longer pulse duration. So maybe you can use a 20, and if you have very, very big veins, maybe you can use 25, but usually it's more 10 to 15 milliseconds, and always 1 hertz. And for the legs, we recommend to use a 6 millimeter spot size with 130 joules. And this is where for the body, you're going to use your vein cards because you need to measure the size of the veins. And of course, when we do spider veins and telangiectasie for the face, you're going to use the Versa mode, so in milliseconds. And once you're advanced, if you wish to use the 4 millimeter spot size for the face, we recommend to use 95 joules. And usually for the face, we do the treatments every 4 to 6 weeks, and for the body, in between 8 to 12 weeks. And of course, for the face, you can combine your veins treatment with rosacea treatment, or you can incorporate it in a 4D treatment. Do you have questions?
We had one question and you just answered it, Marie-France, in terms of how many treatments and how far apart again. So could you kindly repeat?
For the intervals or the amount of treatment?
So how many treatments and what are the treatment intervals?
Okay, so I would say that for the amount of treatments, it's random from one to the other, but usually for the face, I have to say that it is so efficient. With my experience, usually I'm going to do 1 treatment, and maybe the second one, it will be touch-up only. For the legs, I've seen more in between 1 to 3 treatments, and the treatment intervals for the face, it's in between 4 to 6 weeks, and for the body, it's in between 8 to 12 weeks.
Thank you. Okay, thank you very much, and we'll head into the next topic, which is treating eye tags and smooth eye, as well as another condition. So the next 2 topics are going to be covered by Teresa Maloney in Calgary.
Okay, so when you're looking at doing something like this, when you're treating smooth eye, there's different ways, or sorry, not different ways, different patients that are going to come for this sort of thing. You know, the ones that have had a surgery done, they've had a blepharoplasty done, and they're trying to remain, wanting to have and continue to have that open eyelid. And so it's just to maintain the results of the surgery that they had. When you have a bleph done, a lot of times you're going to get anywhere up to 10 years out of it, and people will use Botox, and they will use tightening on the forehead to try to lift that brow just so that they can have a more open eyelid. And so smooth eye is another thing that can help to tighten that and cause a lift. But it's also when you're looking at women, we get to a certain age and we can't wear a shimmering eyeshadow anymore because we have crepiness on our eyelids. This is another thing that would help with that and smooth out the texture of the eyelid with the bonus of making the eyelid also look more open. When you're doing treatments like this, you're looking at doing, you know, anywhere from 3 to 6 of these, and you want to do them about a month apart. I tend to use the R11 when I do this procedure at a really low joule, anywhere from 2.5 to 2.75, because it is quite spicy when you do it on the eyelid. And when you are working on the eyelid, you want to make sure you're putting in intraocular shields if you're going to go directly on the eyelid. If you're just going to go below the brow on the orbital bone, you can lift up to get as much tissue involved as possible, and you can go back and forth that way. And of course, under the eye, under the bottom eyelashes, you can go right underneath and go back and forth. I do anywhere from 6 to 8 passes when I do this procedure. And it's really nice about this is that it's really customizable. You know, we don't age from one side to the other exactly the same. So maybe one needs more than the other. But 6 to 8 passes is where we want to sit when we're doing that. And this is a great combination you can do. You could do smooth eye, and then you could follow it up with a micro laser peel and add that in as well, about 15 microns over top of the eyelid. One of the things I know people like to use numbing cream because you want, you know, pain management is important here. But one of the things that is very important if you are going to use numbing cream for the comfort of your patient is make sure it does not migrate into the eye. Numbing creams have a little bit of a texture of a sand in it, and if that gets into the eye, you can scratch your cornea. So it's very important that we don't overuse the numbing cream and that it doesn't migrate down into the eye itself. When it comes to skin tags and treating stuff like that, those can be done 2 ways. If you have like a tweezers and stuff, you can sort of pull it off so that you're just seeing the base of where it attaches to the skin, and you can set your parameters in under your erbium settings under benign lesions, and you can sort of cut that away with a 2 millimeter and it'll just come off, and then you can cauterize the base of where that skin tag came off. Again, wanting to be very careful when you're on the eye because that is the thinnest skin and we don't want to over treat when we do that. Some physicians out there are taking that and they're cutting, they're using the forceps, they're pulling and they're cutting at the base, and then they're just using the base to cause some cautery there and a little bit of polysporin. They're really easy to remove, but just always keep in mind that it's very thin on that area.
Teresa?
Yes.
I've got a couple of questions here. So the first question would be, what about parameters for treating a skin type 6?
For smooth, does it say for smooth or for removing eye tape? For smooth mode?
Well, this particular person has asked 2 questions. So what about parameters for skin type 6? And please repeat parameters for skin tag parameters. So
okay. Okay, so obviously when we're treating darker skin types, we always want to be cognizant of how much heat we're going to put on. One of the things is that when we're looking at smooth mode and we're working in erbium and we're working with those hand pieces, we're firing at about 250 milliseconds. So we are doing sort of a bulk heat there. So when I'm treating people, if I'm treating the lighter skin types, I might push it to that 8 passes. If I'm going to treat a skin type 5 and 6, I might be at topping out at 6. Again, because we're using an erbium, and what's the great part of that, it's in a lot of ways colorblind because it's not really going for the melanocyte, it's targeting the water, and that's what it wants. It's the same thing about going, up by an eyebrow and getting near it with smooth mode. You're not going to affect an eyebrow. So be a little bit more cautious. If I say 2.5 to 2.75 joules, maybe be down at more at the 2.5 for the darker skin and don't do quite so many passes in that area. But again, it's so much safe because you are using an erbium and the target here is water. Oh, sorry, Trish. And the parameters, if you like I said, you can use the R11 or you can use the PSO3. I tend to like the R11 just on the fact that it's a full hit to the area, and you can actually see the shrinkage, I guess, is what I'm looking at. I can see the skin respond to me putting the energy in. So that's what I like to use. And like I said, for darker skin, be more at 2.5, and for lighter skin, you could be up at 2.75 and do a few more passes there.
Thank you, Teresa.
You're welcome.
And here's this was an interesting topic.
Well, okay, so Xanthos, guys, this one is a tough one. Out of all the benign lesions, and I mean, I'm just going to go under the topic of benign lesions here and different things that you can do. First of all, you always want to make sure, obviously, that the word benign definitely comes into play here before we start removing something. If you remove something that was cancerous, like a basal cell or a squamous cell or anything like that, if you take it off the top, that root is still there and it's still going to be producing underneath. So it's always important that, I mean, if you're working with physicians, that they are looking at it before you do it, or that you have their family physician, if you have a medical director and you're doing these things, that they, you know, that they come back and say, yes, this is benign and you can remove something like this. So xanthos are a little bit tough because, you know, they sit again on the eyelid or under the eye. Those are usually the main places that they are. And because we're dealing with such thin skin here, it is important that we don't go too far. So it looks, what it's done, it looks sort of messy. It looks bloody. It's not the nicest look when it's completed, but the result of it when it heals, it's like nothing had been there. There's no scarring. Oh, this is a great picture of it. This is wonderful. But look where it is. That's very thin skin. So again, under benign lesions, under the erbium settings, you would start with the lowest. And it's what you're doing is you're doing a pass and then you're wiping with a wet gauze and then you're drying before you hit again. Because remember, if it's still wet, then the erbium is going to be attracted to that. So it's about wiping it with wet, drying it before doing another pass. And it's just, you're sort of wiping that yellowish away, that you're just seeing clean tissue underneath. And that's the same if we're doing anything with benign lesions. When do I know I've gone far enough? When I start getting pinpoint bleeding. When you get to that healthy tissue, that's when you know to stop. And it's always like, I rather go back and maybe have to do a little bit of a touch up instead of that I've gone too far. So that's the important thing when you're removing any type of lesion.
Thank you, Teresa. I'm sorry I was a little delayed on getting that picture up, but I thought that for everyone may not be familiar with the term or the condition, so having a something to reference while you were speaking was handy. I was just a little slow. So thank you, Teresa. So
you're welcome.
I do have a, I do want to go back quickly to the smooth eye protocol in terms of, are you able to stack pulses for smooth eye?
I personally don't stack pulses. I know that again, with Fotona, there's so many recipes out there of what to do. I do more of the painting technique when I do this, just because I just feel it's more comfortable and I'm moving the heat. But again, if you're customizing something and you're looking at pulse stacking, you know, maybe in certain areas like, you know, where they have crow's feet on the side and you want to add in a few more there, you could set it on a pulse stack. But I like doing a painting technique over this so that I am not going to build too much heat, but I am still doing it the right amount.
Okay, I've got another question for you, Teresa. It's a statement into a question. I did a full eye rejuvenation for a client. Whoops, sorry, I have to scroll back up. For a client, and treated the entire eye area, both upper and lower lids, with 8 passes and a micro laser peel on top. The swelling was quite substantial to the point where the eyes were nearly shut during healing. Would you recommend treating upper and lower at the same time or split it up?
Well, I recommend doing it all at once. The thing is that how can we tell, you know, once we put heat into somebody's body, their body decides how it's going to respond to it. The people that are going to be your biggest swellers, though, are going to be your really light eye. Those are the ones that tend to swell more. And what you can do is, like you can give products for swelling, like, an antihistamine. Make sure you're using some aloe, some soothing products. Another good thing to do is a vinegar soak. Take a cup of water, 1 tablespoon of vinegar, and put your gauze on top of their eyes after, and that will also help reduce swelling. The thing is that are we doing something that's counterbalancing here? Because we do want the heat, but swelling is something that can happen, and it's not always predictable with us with what we do. So if you do 6 passes or you 8 passes, was that the difference that made the swelling? I have a colleague that I work with, and she's Irish, and she's got the lightest blue eyes, and I can use the parameter that I'll use on 20 people, but I do it on her, and her reaction is always really exuberant. And it's just the way her skin responds to how I put the energy in. So we just need to be prepared for that. We need to tell this to our patient or our client. Maybe sleep elevated the first night. Those are all things that help, but it's always preparing them for, you know what? You're going to get some swelling here, because we're putting heat in an area that's very sensitive.
Thank you, Teresa. And I can speak to being a patient of yours personally with the smooth eye procedure. And I did sleep elevated for 2 nights with 2 pillows behind my head. And the one night afterwards, where I had forgotten, I did have significant swelling around my eyes. So the post-care is especially important. Thank you.
You're right. And I just want to make one more point, Trish, here, because I know some people have done it. It's also important that we do not put an occlusive ointment on. Like, do not use, this is not where if you're doing, you would put Aquaphor on. You would just want to do like a soothing cream, nothing that you lock that heat in. When we do micro laser peels or we're doing deep fractionating and things like that, that heat's coming out in our plume. That's why we occlude there. But in this case, please do not use Aquaphor over doing just smooth eye.
Thank you. And just quickly, Teresa, can you review the hand piece you would use and the parameters for the eye lesions?
You know, guys, that's a tough one. I mean, if you're looking at where I start with the presets under benign skin lesions. So usually I'm looking at, most of them start around 18 microns, which I think is 3 joules. And I use a 3 millimeter spot and go down to a 2. I never go above a 3 millimeter. I start at 3, go down to a 2 if I need to clean it up at the end. What makes me change my parameters is when you do a pass. So if you're treating a lesion like an actinic keratosis or a seborrhea keratosis, or treating something like that, that's when you do those first couple passes and you go, oh, this is a lot thicker than I thought it was, and then I might go up in my my microns because I don't want to be playing there for a long period of time and build the heat and build the heat. And in this, you're always working in micro short pulse because you don't want a lot of heat there. So it's just important that when you start the lesion, whether you're going to go up or down is going to depend on those first couple passes of what the thickness is of the lesion you're targeting.
Thank you, Teresa. We're going to move on now. We're going to move on to pores, and we've got Siobhan and Sarah Jane who are going to speak to this topic.
Hi, I'm gonna take the first round here. So when we're looking at pores and pore sizes, we know that genetically this is determined by our genetics, having that appearance of large pores. But we also know that other factors that can affect the size of our pores would be oily skin, sun damage, certainly a smoker, or pollution particles. Other aging factors can certainly make our pores look bigger. And while we can't change the size of the pores that we're genetically born with, we certainly can help along the way to minimize the appearance of those enlarged pores that we can sometimes see or patients are coming with. I do think, again, it's patient expectation needs to be managed during the consultation and just reminding them, you know, these are your genetics, this is what you're born with. But there certainly is that combination approach to the overall skin health that does need to be explained to the patient, you know, using a medical grade skincare. Patient compliance is extremely important in that part as well. And they need to understand that there's a part that they have to do, making sure that, you know, that they're cleansing the skin at the end of the day, making sure that I always like to recommend specifically a toner as well, whether you're wiping or spritzing that toner on, that certainly can help to unclog the pores and kind of flush the pores out as well, or you're using that a wiping technique on a cotton, obviously maintaining regular exfoliation at home. So again, it's that patient compliance, you know, you have to participate and do your part. There are maintenance treatments that can be done yearly for a patient, like our Bella MD system that we have. This provides infusion, so there's other added benefits for skin health, but also there is an extraction portion with the device while you're infusing. So certainly help to keep the pores clean that way as well. And also just educating the patients, you know, if you're not doing your part as far as cleaning the skin with medical grade skincare, also understanding, you know, these are the factors that affect you know, pore size. Pollution particles can get trapped in there, a buildup of dead skin cells, buildup of semen. If you're a smoker, certainly around the mouth, that smoke is a form of pollution as well. So those particles sitting on the skin and clogging their pores. So it's up to you to do your part. But what we can do is maintain with regular treatments like our Bella MD that we carry. And you certainly can introduce laser treatments. And Siobhan's going to take that section on there. But just what kind of laser treatments can we provide for a patient that help give the appearance that they're smaller? You know, minimizing the appearance of the pores at that point. So I'm going to pass that on to you, Siobhan.
Thanks,
Thank
Sarah
you.
Jane. Yeah, so like Sarah Jane mentioned, guys, it's genetic. So yes, we could do different treatments with the SP Dynamis to help the appearance of the pore size. There's multiple things we could do with this. We could use the ND-egg or the erbium. We could use FRAC3, you know, targeting the skin imperfections, which is going to make the texture and the tone look better. We could do smooth mode, helping with the appearance of shrinking of the pores as well. And depending on, you know, whether the patient is okay with some downtime, we could even do, you know, some micro laser peels over the pores, over the nose especially, and or the fractional skin resurfacing. I would suggest just staying within the SP mode while doing those, or at least starting with that and seeing how the skin reacts and how the client is accepting the downtime, and then moving our way up if we want to, you know, add a little bit more coag with that. But definitely, you know, driving home with that message of that they have to do their part as well. And that, you know, the laser is always absorbed by the skin and the tissue much better when they are taking care of their skin with those medical grade skincare products that Sarah Jane mentioned.
Thank you, Siobhan and Sarah Jane, for addressing the pores. We're going to move on to the next topic, which was a question around urinary incontinence. And I just wanted to stress that for Fotona, this is I've got pictures of the hand pieces. This is not something that a service that everyone provides. The hand piece is an additional hand piece. It's mild and moderate. So for those ladies that are joining us, or even those husbands that have heard their wives say, "I've laughed so hard I peed," or they're running and they've got a little bit of leakage, this is the perfect treatment and opportunity for them to have some relief. So I'll just show you quickly the hand pieces that you may be familiar with if you're providing this service, or this may be something new to you. So this is what we call the G set, where we're using the PSO3 and the R11 for gynecology. And so specifically around incontinence or urinary leakage, we're looking at using the erbium, and we're using smooth mode. So this is something that Fotona introduced in 2012, and it's been highly studied. There's numerous clinical studies on the efficacy here. And I'll just show you quickly, this is the other hand piece. This is the G runner, which is looks a bit like a drill, if you will, but it's an automated procedure. This is something that would be attached And so what we're doing with the both applicators, or just in the sense, the procedure is called incontilase, and we're really looking at a laser-induced thermal effect that will stimulate collagen, and it helps with the remodeling of the mucosa in the tissue. So more specifically in the region of the vestibule and urethral orifice, as well as in the area of the anterior vaginal wall. So we're looking at shrinkage and tightening of the tissue in the urethra and anterior bladder wall region, so that our female patients have that return to continence. So we do recommend doing 3 treatments, 1 month apart, and we do provide a scale, some sort of something that you can do in the consultation, where it's a self, the patient would fill it out in terms of, so you can assess the degree and the frequency of the leakage or incontinence to figure out when this leakage is happening and figure out how much. Because if it goes beyond just the odd, just a little bit, and you get into full on, instead of just the stress urinary incontinence, and you get onto other degrees of incontinence, this isn't as effective. So you'll see that immediate collagen contraction during the first treatment, and then that new collagen will be deposited in about 3 weeks' time. The mature collagen forms in about 6 to 8 months, and that's that final result, is that remodeling that causes the tightening of the vaginal canal, and then those tissues are able to support the urethra. So why does this happen to women? Well, pregnancy, certainly multiple pregnancies, if you've been pregnant and had a baby bounce on your bladder, childbirth, menopause with that decreased estrogen, generally speaking, the aging process. There could be a neurological a piece to it. And, there's that decrease in the collagen that we experience in our body just in general. So I've got a question here. Let me see as I go through the questions. Oh, I haven't got a question specific to gynecology. So that would be, this is an extra service or that can be provided if you don't already provide. And as I said in the introduction, we do have Nikki Havers, who is our resident gynecology nurse on the team, that does help us provide a very comprehensive education program with urinary incontinence as being part of our gynecology program. So as we move away from the bladder and go back up into the mouth, we're going to have Marie-France talk about sleep apnea.
Okay, so Tricia, we want to talk about snoring treatment, right?
Correct.
Okay, so snoring treatment, it's a lunchtime procedure, and it's more and more popular now. It's non-ablative. It doesn't require anesthesia. We see immediate results from the first day. And the idea is to use the smooth mode to do a bulk heating. So, and the smooth mode is very, very special. It's very unique because it's a thermal effect without any ablation. And it's 10 times longer than the standard erbium on the market. So usually standard erbium are in between 25 to 45 milliseconds. Us, with the smooth mode, we have a duration of burst of 250 milliseconds. So the idea is to create a bulk heating on the uvula, the soft palate, the surrounding tissues, and also each side of the thumb. So we have 2 steps to do that. I have to say that with years, we modulated that treatment. So this is what we do. We have 2 steps with 2 end pieces. So the first step is with the PSO3. We use a 5 millimeter spot size with 12.5 joules. And the idea is to use the painting technique and to do 7,000 pulses and also constant movement at the back of the throat. And the patient will feel heat, but it is not disagreeable. So, and we have the second step. This time we're going to use the R11, and PSO3 is a pixel end piece, and R11 is a full beam. So that's the reason why with the second step, with the R11, we're going to use in between 2.75 to 3.75 joules. Usually I prefer to use 3.25 joules, so it's very comfortable for the patient and I have very good results. And for the step 2, we with the R11, we use a 5 millimeter spot size. And usually we're going to use the hertz in between 2 to 3.3 hertz. And the second step, we're going to do 3,000 pulses. So at the end of the treatment, we have a total of 10,000 pulses. So 7,000 pulses with PSO3 and then 3,000 pulses with R11. And the idea is to do a bulk eating of the mucosa. So that's very important. The patient shouldn't drink before the treatment. However, they can drink and eat after the treatment, but not before. And usually we're talking about 3 treatments, so a package of 3 treatments. So the treatment intervals are day 1, 15, so 2 weeks later, and then 45. However, if you take a look at the Malampati score, if you're a 1 or a score 2, yes, we're going to do 3 treatments. But if you're a score 3 or 4, we need 3 more treatments. And of course, this treatment needs maintenance. So as soon as you start to snore again, you need maintenance, and it's random from one patient to another. And if you wish to measure your snoring, there's an app in the App Store, and it's called iRonfle. So you can see at, for example, if you start to snore at 12 o'clock, then more at 1, less at 2. So it gives you a very good idea of your snoring picture.
Thank you, Marie-France. I've got a question around what is the name of the app? Can you spell it, please?
Yes, it's called iRonfle. So IRONFLE.
Okay, wonderful. And we'll circulate the name of that app in the email after. I've got 2 other questions.
And you know, Tricia, this treatment can save relationships.
Oh, I agree with you.
Yeah.
I agree with you. How much time before the night lace treatment should a patient avoid eating and drinking again?
Well, I would say like 30 minutes before, because we know erbium is attracted to water. So if you drink just before, we're gonna have too much water in the skin. It's because erbium is highly absorbed by tissue water. So I would say 30 minutes before, I would avoid to drink and eat. But right after, if they wish to drink a glass of water, there's no problem at all.
Great. Thank you, Marie-France. Okay, so the next question we had a question around the T-runner and protocols. And I think we'll have Siobhan start the conversation, and I would like the other panelists to join as well.
Okay, hi. So I will start and just pulling up my parameters here. Okay, so what's different from the T-runner versus our handheld hand pieces like the R11 or the PSO3 when we're using smooth mode is we have something called V-smooth. What this stands for is variable smooth mode. So it allows us to pick our milliseconds, instead of just having the standard 250 milliseconds with smooth mode with the PSO3 and R11. So we have a range from 125 to 625 milliseconds based on what area are we treating? Is it more superficial, or can we or do we need to go deeper based on the area? We also have something called STP, which is the surface temperature parameters. It shows the real temperature impedance, which is going to let the technician know how the skin is reacting of the patient if it's too hot. We need to keep this under 100%, and your light will go red if it's above that, if they're not using any anesthetic. If they are using a numbing cream, they can, if they can tolerate, go above that 100, but it is a bit spicy. We suggest that you use in between 4 and 6 stacks depending on the area, as well as 4 and 6 passes. If it's too hot for the patient or too spicy, we want to decrease the stacks and number of passes. So maybe we decrease 1 or 2 stacks from the parameters and we do 4 passes instead of 6 passes. And then we have joules as well. Tricia, there's a number of parameters based on the treatment area. Do you want me to go through each, or do you want to send to the group?
We're going to send an email to the group afterwards of all the latest protocols for everyone's reference. So if there's something that you like personally, share that. But as a baseline, we'll send out the updated parameters to everyone on this call.
Okay, and I'll just say that, you know, for our darker skin types, I'd start or suggest starting with a lower fluence than maybe suggested in the parameters and see how the patient reacts to it. There is new protocols developing with new software coming out with the T-runner. So again, like Tricia mentioned, we'll be in contact with you if anything changes with this as well.
Thank you. Is there anybody else on our panel that would like to add their experience with the T-runner? Okay, and I don't have any questions, so we'll move on. And the next is benign lesions, and Teresa did touch upon that a little bit, but I'll have Teresa. Is there anything you'd like to add, Teresa?
Well, I just think, like I said, when you're treating a benign lesion, first of all, that it is benign when you're doing it, and go slow and steady with it. You don't want to, you know, have your energy up so high that you're taking too much off at a time. It's about having the control of what you're doing and sort of like you're sanding it down. That's sort of how you're looking at it. You're erasing it from the skin. And it's just important that, again, that wet gauze and dry gauze, when you're wiping it away and then you're drying it and going and doing another pass, it's just important that you're really watching that and watching that skin reaction. When you get to that pinpoint bleeding, you know you're at the healthy tissue, and then it's time to rein it in, maybe go a little bit along the edges to just give it a nice fine tuning there. But that's my biggest thing with benign lesions, is slow and steady and make sure it's benign before we treat.
Thank you, Teresa. We're going to move. Oh, We're going to move into acne scarring, and again, this is a bit of a tag team with our skin specialist and with Siobhan.
Do you want me to go first? I could go first. Okay. So we've got some parameters with the FSO1 that I wanted to touch base on and kind of focus on what to do with our darker skin types. So first and foremost, it's another situation where we kind of want to move slow and steady. So not necessarily being a cowboy and using the highest amount of joules or the deepest microns with this. So making sure, I would suggest test patching for 72 hours, any of your darker skin types, your 4, 5s, or 6s, starting with the lower of the two fluents of your 80 joules, which is your depth of 274 microns, staying within that SP mode, which is that 9 microns of coag, is where I would start with this. And then, you know, seeing what how the skin reacts, giving that 72 hours, making sure there's no hyperpigmentation from your patient, and then inviting them back. Again, it's, you know, setting that expectation for your client. It's not a one and done. There's going to be multiple treatments that are involved, typically minimum of 3, depending on the depth of the acne scarring, and then slowly moving your way up. But I wouldn't suggest going more than LP on any of the darker skin types. You just run into such a high risk of that hyperpigmentation. So my advice is just, you know, stay slow and steady with it, starting with the lower amount of joules, and definitely with the SP mode to start with. You could go up to 3 passes for a density up to 15, because remember, we're using a fractionated hand piece. The downtime, you know, they've got that healthy zones of injury of the skin, so the downtime isn't so bad. They have some pinpoint bleeding. The post-care they need to, you know, go through as well, you know, using those vinegar soaks like Teresa mentioned, elevating themselves as well. So they've got to take care of that themselves at home too, along with the skincare protocol, which I'll let Sarah Jane take over.
Excellent. Thanks, Siobhan. And I thought I'd let you tackle that one first because, you know, with your acne scarrings, you know, obviously that depressed scar generally sits below the surrounding skin. And we know that they're formed when the skin is healing and potentially not enough collagen was made during that wound healing. And we know that there's different types of scars with acne. You've got your box scar, your ice pick scars, we have rolling scars. And while certainly topical at-home treatments that you can prescribe to your patients with medical grade, you could use your alpha hydroxy acids, your lactic acids, retinol, salicylic acid, always being mindful with your pre and post care for your patient as to, you know, when you would recommend that they stop taking those retinol, salicylic, lactic, depending on what you have recommended to them. Need to cease using that before coming in for a treatment. But I certainly am, I love combination approach, and I do think skin health is an overall global approach. There's some other in-office procedures that can be done to help with those, your microderm, your chemical peels, but certainly I'm definitely pro the protocols that Siobhan was speaking to as far as your scarring goes for acne.
Thank you, ladies. I haven't got any questions so far, so we'll just move ahead into the next topic, which is treating those darker skin tones. And I believe, Siobhan, you're going to speak to this as well.
Yeah, I mean, it's a bit repetitive. We're going to just, again, go slow and steady with our darker skin tones, meaning our skin types for the 6s, you know, making sure we get them in for those test patches and waiting that 72 hours because we know that these reactions or potential burns can take that long to appear. So whether it means lowering your joules on the settings, or parameters if you want to take it slow. Again, if we're talking erbium, staying in that micro short pulse or short pulse mode and assessing how the skin reacts is extremely important. Going back to skincare, maybe starting with something like the Bella or a microderm so that the skin absorbs the laser better as well, or chemical peels can help too if we're talking pigmentation that they're worried about. But I think the approach is just slow and steady with our darker skin types, doing those test patches and waiting that 72 hours.
I do have a question for you, Siobhan. What about micro laser peels, non-ablative? Are we to be overly concerned with darker skin types?
Yeah, we still want to stay within the SP mode. Again, slow and steady, we can move them up to the LP, but I would suggest for their first treatment, starting with the SP, absolutely.
And would you do a test patch for non-ablative on a darker skin type?
You can. It depends your comfort level or if your patient's ever had laser treatments. I would say it's always safest to do a test patch.
And I would agree with you. Is there anyone else on the panel that would like to add?
I'll speak up here on this. When you're looking at again, micro laser peels and ablative procedure, when you're doing something like that, and same with the FS01. So I mean, your face is very forgiving when you're doing something like this. It heals the best. It's the best place to treat. As you move down the body, that's when you can run into PIH and getting things. If you're treating stretch marks or going after a scar, you want to do something in those ways. So it's important that you're letting your patient know, look, I can help reduce your scar, and I might be able to make a difference here on what your scar is going to look like. A scar is a scar is a scar. It's always about getting that improvement on it. But in the end, we could get to some hyperpigmentation here. And that's where skincare and the Bella MD come in to help that after the fact. It's just important to let them know this is what we could end up with. And it's not necessarily on everybody that it's going to happen, even on really dark skin. But once we work on the body, it's sort of, again, it's sort of like when I say putting heat into the system and you can get swelling, it's the same thing in these cases. You can also pre-treat so that you take that risk of PIH away. Put them on products that help, decrease that melanocyte and push it back and recede it, so that when you do the treatment, you're going to be safer treating these darker skin types. You have to remember here, we are using something that wants water. That's what its target is. Black skin, white skin, it's all about water. So when you're doing these ablative procedures, that's what you're keeping in mind, is not too much coag, like Siobhan said. Like, work in SP mode when you're treating those darker skin types. Don't play with the amount of coag that you're putting in, because there's the heat and that's where you can lead to more. And especially when you're on the body, stay in SP mode.
Thanks, Teresa. And while I've got, I'll send this question out to the panel as well. And how would you approach Asian skin types?
Well, it's the same. I mean, with Asian skin, Indian skin, black skin, anything that I'm doing when I'm treating a dark skin, I'm always taking into the fact that they have a larger melanocyte. White people, black people, we have the exact same amount of melanocytes, except in darker skin, they're larger. So it's always more of a target. But that's the wonderful thing about the erbium. Because I'm dealing and wanting with water, I would do a 20 micron peel on someone who's Asian, and I would do it on someone who's Irish, in those cases. But when I'm looking at the body, PIH is where I'm really concerned when I'm getting into those darker skin types, because that's where that can happen. So pre-treating with products, doing things to help decrease that is your safer bet with stuff like that.
Thank you, Teresa, and thank you, Siobhan. So we'll move into the next topic, and the next topic is melasma. And I do have a slide. Marie-France is going to speak to this, and she did send me a before and after for you to see as well. So I'll let Marie-France talk about melasma.
Okay, so when I think about melasma, I always think about melasma one day, melasma forever. So we can control melasma, but we can't eradicate melasma. And that's the reason why a lot of people are struggling with that problem. So the lady that you see on the screen, I did one treatment for her, and I did it at at Dr. Chloé Sylvestre Clinic in Montreal. And when I met that young woman, I said to myself, you know, she has beautiful eyes, she's a beautiful lady, but my God, we have a real problem here with her skin. So this is what I did. I did only one treatment, so that before and after that you see, it's only with one treatment. So I think that it proves that the treatment that we have for melasma with the SP Dynamis is very efficient. So this is what I did for her. So I customized the treatment. So I did two steps. So the first step was with the N-Piece FSO1. So FSO1 is a matrix of 9 by 9. So we have 81 microchannels. And the idea was to break the pigment. So I use 54 joules. So 54 joules, you can reach a depth of 185 microns. So it means that you are at the epidermal dermal junction. And I use the Turbo number 3. So Turbo is an incredible tool. Well, you want to fractionate the skin, because the Turbo mode allows you to apply a beam multiple times, but to a single treatment spot. So I used the Turbo 3 for that treatment, but the pulse can be repeated up to 6 times. So if you wish to do fractional treatment for wrinkles, scars, so you will probably use a Turbo 5 or maybe a Turbo 6 because you wish to reach a better depth. So I did 2 passes, but only where we see the pigment. And after I did a micro laser peel, 15 microns with PSO3 and piece. And why I did that second step, it's because I want to even the complexion, and the micro laser peel is like a vacuum. So I wanted to remove all the dead cells on the skin. In that kind of treatment, I prefer to do that from October to May, because during summer, there's a lot of sun, a lot of heat. So I really prefer to do that during winter time. And I suggest 1 to 2 treatments. And I would say every 4 to 6 weeks apart, but usually I prefer to do that once a month. And of course, after the maintenance is very important. So we can use bleaching agents. We can do microderm treatments. After the treatment, this is what I did. So of course I applied cold compress and I used the Zimmer. And as soon as she was more comfortable, I applied occlusive ointment. So I applied Aquaphor, but also we can use Vaseline. And of course, for 3 days, she had to apply the Vaseline at home because you really need a good protection. You need to mimic the epidermis. And after 3 days, of course, you can use a moisturizer, but without dye, without any perfume, and of course, a very good sun protection. But when you have a problem, when you face a problem like that, you need to apply sun protection every single day. It is non-negotiable. And talking about sun protection, we have mineral makeup. So for that kind of problem, it's a very good tool to put mineral makeup, and we have color science. So that lady can use the SPF 50, the powder that we have, to protect the skin and to make sure that she has a very good sun protection. So that's the result before and after with the treatment that I did, Tricia.
Thank you, Marie-France. I'm wondering if you could just quickly repeat your parameters for both steps. And then what I will do is I will share this to the group. So which handpiece are you using, and what are the parameters, please?
Okay, so the first step, I went in depth with FSO1. So I used 54 joules. So with 54 joules, you reach 180 microns. So you are at the junction epidermal dermal. This is where the pigment is located. And I used the Turbo 3. And for the coag, I forgot to mention that I use the SP mode, because with a problem like that, you don't wish to put heat. And for the second step, and with the FSO1 end piece, the treatment was localized. I went only where you see the pigment. And for the step 2, I did a micro laser peel everywhere with PSO3, and I used 15 microns.
Thank you, Marie-France. And maybe I'll have you send me those settings afterwards so that everyone can refer to this protocol. And I appreciate you sharing the photo. It's a very good visual, and I hope this is something we can share, use this method in our future roundtable sessions where we're able to share case studies.
Yes, it won't be a problem. Dr. Silvestre allowed me to use that picture.
Wonderful, and we thank her for that. Thank you. So last but not least is we go from the face to the toenails, and toenails are part of what I'm going to speak to today. I have a bit of a nasty visual for you just to show you sort of what toenail fungus looks like. You know, our toes are often in warm socks, especially now in this particular season. So they're in a warm environment anyway. Never mind, our toes are exposed, our feet are exposed to different kinds of fungus and sometimes yeast. So those toenails become thick and warped, and they're a bit oddly shaped, and sometimes it'll spread to the surrounding skin as well. And so the toenail will appear yellowish with white dots and very thick. And so it really is looking at a combination approach. You're doing your ND-YAG, you're doing 3 passes over those affected toenails. And if you do have 1 or 2 toes, it is wise to do a treatment on the entire foot, because chances are it may spread to those other toes. And really, it's heat. So it's not a tremendously comfortable treatment, but it does heat up the tissue. And then as an add-on, using the FSO1, 250 microns to go on top of those 3 passes with the YAG. You're also looking at potentially having an antifungal cream, or there is an oral tablet, and these are the prescription cream and tablets are more effective than you would with just an over-the-counter product. And also, it's really important, because that nail becomes so thick and warped, to file it down. And back in the days when we were able to have pedicures, here in Ontario, we're in total lockdown. But some places where you go for a pedicure, they use a Dremel filer, so just to file that nail. So using something of that, not just your typical nail file, to really file that thick nail down so it allows that energy to penetrate more effectively. And you're also shaving away some of that nail that is infected with the fungus, and you're getting at the root cause, if you will. So that's, let me see if I do have a question about toenails. Let me scroll through. It's kind of hard to talk and how many passes with the FSO1. So you can add 2 to 3 passes. Again, you want to it's a prickly. You could do 1 pass. You could do 2 passes. It is, as to Siobhan's saying, it is a spicy treatment. It is a bit ouchy, but again, and you can do that if I'm not. I'll reach out to my fellow trainers, but I was doing this once a week. I think you can do that as often as you can just to get, but it does take a long time, and that's why the combination approach is the best method, to have that topical as well as the heat to kill the fungus, and keeping that nail file down and keeping those nails short. So there was the Jublia, which is the topical. When I had the person I was treating avoid the day of treatment, not applying it that day, and applying it after that, the night of that treatment day. So that was the frequency. And I will look into some of our parameters and make sure that everyone has when I send out the parameters around toenail fungus, it's not something that people, women, if they have it, they'll keep their toes painted or they'll keep their feet in socks and shoes. It's not necessarily a nice thing to have. So that concludes our topics from the questions that came in from last week's registration. I really appreciate everybody sending topics, and it helps us to know what the questions people are asking, what you're doing, what you need help with from a coast-to-coast basis. I look to hosting these Meet the Trainer sessions. You get an idea of who is who. You can put a face to the name. And we can also look at trends, what's happening in BC versus Ontario, or Montreal versus Vancouver. We can look at who is doing what, and really this is a group of users, and we can help one another to learn. So that was really the goal of putting this together and having a very informal session, as well as you meeting the trainers. So I really appreciate everybody that has joined us today. We did not take the full 2 hours. I wasn't sure how many questions we would have, but I do appreciate, I applaud the panelists. So thank you for all of your insight into your experience. I will send out an email with all the parameters. The last slide I do want to share. So if you want to get your phones ready, here is the emails of all the clinical trainers across the country. So if you have a specific question and you're located in Alberta, Teresa's more than happy to help, and so on and so forth. Ontario, Quebec, Sarah Jane again is our skin health trainer, and all things gynecology is Nikki. There is a quick question. Quick question before we go. So before there's an update on the system a while back, you would need to exit the live screen to go to the arrow to see the pulse count. Since the update, the black screen while using the laser has a pulse count on the main screen. Now, if you compare the two, the pulse count are completely different. The black active screen counts about 1/5 as fast as the old pulse count. Can someone please hop on and answer this question quickly?
Hi. You know, the thing is that if you're looking at the black screen, it's not doing the pulse count. That you're right. That it's not the right pulse count. So it's still the way you have to do it. You have to take off calibration and go to the arrow that's at the top and click that, and then that gives you your pulse count. You always want to make sure that's at 0 before you start the next treatment. And I don't know if a lot of people realize too is that when you're on, like for example, doing piano mode, skin tightening, when you're in that black screen at the top are 3 zeros on the right hand side, and that's your counter that'll do the time for you. So once you're heating to 40 degrees and then want to time it, you just have to touch those zeros and it'll start. So you don't need an extra timer. But yeah, you still have to go back in the Erbium if you're doing smooth and doing that, and click that back button to see what your pulse count is.
Thank you, Teresa. I just wanted to get that question answered right out of the get-go. So with that, I'll conclude our Meet the Trainer session. Again, thank you to all that have joined us today, and look for that email tomorrow where we'll send out all the parameters. So thank you very much.
Thank you.
Thanks.
Thank
Thank you
everyone.
very much.